Thank you, Dr. Saxena. I will tell you her introduction is I meet a lot of nephrologists, and half of them do not even know their patients are taking 2 cycles or 4 cycles or what's going on. And I'm very surprised to see they even don't know fill volumes that well. And when I met Dr. Saxena, she was giving a talk at ISPD, and she was particular about fluid calculations. And I was very impressed with her talk. And at the end of the talk, I approached her, I exchanged the number, and her work at Stanford is remarkable. Her work, and she's training 240 nephrologists every year. It's an honor for us, for all of us to learn from her today. And my co-host here is Doug Wilkerson. We also have Rod here. We have Dr. Numan here, and we have a whole bunch of nephrologists. Feel free to jump in, and we will first do her introduction, and then we'll jump into the PD prescription. That is the topic of the day. Thank you, Dr. Anjali, for joining us.
You're very welcome. Thank you
So
for
why don't we
inviting me.
start with your introduction? A little bit of your story, your life story. We get people would like to hear from you.
Okay, great. Yes, thank you. So, thank you all for joining. I'm really honored to be invited today. So, yeah, I'm a nephrologist out in California in the US at Stanford. And I started my medical training on the East Coast, actually. I was born and brought up there. Then I attended Duke University, and then I went to Wake Forest for medical school. And there was actually a famous, a very well-known nephrologist, big in peritoneal dialysis, who's retired now. His name is John Burkhart. And he
Pretty
was one of
good.
my first mentors.
Pretty good
And
drummer too.
very good drummer. Yes, he's a very good drummer. So I left there and I went to Stanford for residency. I did not know I would be a nephrologist, but I ended up choosing nephrology for a number of reasons, including the rewarding nature of chronic care. I was telling folks earlier before we started how nephrology is so rewarding because you get to know the patients over years and years. And then my mentor I went and continued and did a fellowship at Stanford, and one of my mentors at that time was the late Stephen Guest, who was really a pillar of nephrology for the late 20th and early 21st centuries. And he actually was running the peritoneal clinic where I now took over for him. So he left the hospital for other ventures. And he recruited me to take over for him when I was in fellowship. I got recruited to be the director after he left. So I took on all his patients and that clinic, and then I've been there for 20 years now. So we've grown that clinic. We started out with like 15 patients. So we now have like 75 patients. Probably would have more if we had more nurses. We're an independent peritoneal dialysis clinic, so we're not owned by a big company like DaVita, which gives me a lot of not only control, but also a lot of ability to adjust things, to teach, to allow for individualization of therapies, which big corporations have a harder time doing. So we'll talk about that. And in terms of teaching, so I'm a clinical professor at Stanford, and so I'm in charge of teaching the fellows not only general nephrology, so we always have 2 on site with us rotating, but I also run the home dialysis education, and in that venue, I the co-director now of a course that we've done since so John Burkhart started a course in 1999 called Peritoneal Dialysis University. And that grew into home dialysis university, so incorporating hemodialysis at home. And I joined that faculty in 2007. So, and through that course, we do about 4 to 5 seminars a year It's a 2.5 day seminar where we teach in-depth home dialysis, peritoneal, and home hemo. Everything from patients down to very nitty-gritty patient prescription writing. We talk about physiology, very detailed physiology, and we have 4 or 5 faculty each time. So each course is about 50 or 60 nephrologists or fellows. So I've been doing that since 2007, and now I co-direct that with Dr. Joel Glickman. And then I've also been involved with ISPD, so bringing this internationally. So one of my passions is low income, lower income countries. So in 2018, a colleague and I started a project in Sri Lanka where we helped them develop peritoneal dialysis. So there's an epidemic of CKDU in Sri Lanka, in the middle of the country. You may be aware of CKDU, and there were I guess it's probably similar to Pakistan where dialysis wasn't very available, but hemo wasn't very available either, just due to the topography. So a clinic was starting peritoneal dialysis, and we helped them develop that, and we would do site visits twice a year. And now I think they have over 800 PD patients, and they started out with like 50. So it's really been very successful there. Now it's all CAPD. It is true, it's all CAPD. But it's really lovely to see that brought to a place where it's, very unlikely to get that kind of therapy. So now I'm just involved mostly in education. This is my very strong passion of education and patient care, and peritoneal dialysis is my specialty. So that's the background.
That's wonderful. Our passion is right there. We also want to really care and change this landscape for the people who do not have access to dialysis. Just look at Pakistan. 300,000 people need dialysis, 30,000 get it, 90% of those die without dialysis. There was not a single PD machine or proper service before we launched. And looking forward to take your guidance into so many countries where we can go together. And that's where we are. That's our passion is so much aligned. So let's uh, jump onto the PD prescription, because nephrologists would like to see, and I would like to see, and in the future machines, we would like to see how we should design the better treatments for the patient.
Well, so yeah, I think the most important thing in my mind is the individualization of the therapy. So every patient, it depends on how much nephrology care they've had. If they've had any nephrology care, hopefully they've arrived at end stage with some residual kidney function. And the difference between peritoneal dialysis and hemodialysis is that every extra exchange you do with PD has risk. So not only is it exposing the membrane to additional sugar, it's also an additional, if you're doing CAPD, it's an additional hookup, additional connection, possible infection risk. It's a burden. So either cycler or CAPD, additional exchanges increases the time on therapy, which increases the burden, which increases burnout. So over prescribing PD is harmful. And I really believe that we should all start with an incremental prescription. There's a big study being undergone right now to prove that that's safe, but we've been doing it for years and years, and it seems to be, no, it does. It's definitely safe to do, as long as you are measuring residual kidney function or reassessing the prescription often. But I think that's the most important thing, is a patient should be assessed in the very beginning and not just given a kind of a standard prescription, because additional PD is harmful if you don't need it. I didn't even mention the calories, by the way, every additional exchange. So that's number one. Number two, I think we do need to frequently reassess the patient for changes to the prescription if we're going to be individualizing it. That doesn't mean they need to have a lab test every week or, in some cases every month, but every month is is fairly standard, but we do want to look for some changes and adjust prescription accordingly. I think number three is super important is to take the patient's lifestyle or into consideration with the prescription. So what does that mean? That means a patient who is working or whose caregiver is working would have a different prescription than somebody who is a mother who has to be out of bed, at night, taking care of little children. So for her, maybe a cycler wouldn't be the best thing to start with, and maybe it would be better down the line. So you have to take that into consideration, and also the time of the cycles. So if you're going to have a patient on a cycler, you really want to know what is their sleeping time. You don't want them to lay in bed waiting for the machine to end, because they'll burn out very quickly. At the same time, you don't want too short of a time, because you don't want the exchanges to be so short that you impede the efficiency of the cycles. So all of these things really take a proper assessment of the patient. When our patients come in, even before we start training, we ask them to tell us a number of things. What is your daily schedule? What time do you go to bed? What time do you wake up? What are your activities during the day? If they, for example, if they have to go out every day to pick up children from school at 3 p.m., well, a day exchange, has to be timed. So these are the things I think are very important.
So quick question. We will cover the manually, how should we program, and we'll go into presentation. But quick side kind of question is, in the world of AI, you have smartwatches, you know what kind of activity they are doing. Maybe CGMs are there on the body with glucose monitoring systems. Do you see any path forward in the next 2 to 4 years where customization can be done automatically from day to day, or that's a bridge too far?
Well, I don't know. Yeah, I don't know what are the limits of AI in terms of technical. However, I think you already see certain technology and development, for example, technology where UF, the ultrafiltration, is being assessed on its way out of the body, it being assessed for the glucose content so that you can reinfuse glucose periodically at 30-minute increments instead of having to do these large exchanges of high glucose. So I think that's already being looked at. I mean, in terms of using that for prescribing, I think there could be a model where you'd input certain things, or you could take it from something like a smartwatch. I think again, that's very individualized because not everybody uses these devices in the same way, but it's definitely an opportunity.
Right. So, and do you think weather data can be a key factor into, like, if it's a string of hot days in 10 days and people are losing more through sweating in Texas versus, do you see that can be a good, or that's a bridge too far?
Oh, that's actually a wonderful idea. We do see that trend on and hot during heat waves that patients certainly do come in hypovolemic, and if not, at least adjusting the prescription, at least it would have an alert of looking at ultrafiltration changes. Probably the first step with using that data would be to integrate it into the cloud data to send alerts out to the practitioners or the patients.
Sorry for that. So that's good. So Doug, do you have a question around prescription? I will let, or any nephrologist who has any question about prescription.
Well, I'll go ahead and ask one. In many walks of life, Anjali, size matters, and that's particularly true in dialysis. And I wonder if you could explain how you approach patients of different size, particularly, although this isn't a particular problem in South Asia, In North America, we run into patients who can be over 100 kilos fairly frequently. And so how is the prescription necessarily adjusted for these larger patients?
Oh, that's a great question. And I think, I'm not sure if you had jumped on yet, but do you want me to share the case now of the 90-kilo man?
Yes, that's a
That
good.
might be,
Yeah, I think
yeah.
that's a
So,
perfect lead in.
yeah, thanks, Rod. So there's a case that I had shared a little earlier. I'll just share it with all of you now. Um, Let me share that. Can you see that? You see that, right?
Yes, absolutely.
Okay, all right. So this is similar, like a 90-kilo. You could make him 100. In fact, let's just make him 100 kilos. Okay, so this is 100 kilos, and this was just showing you how I would kind of go through this with our nurses and fellows and nephrologists, how to prescribe. So, for example, this 50-year-old man, 100 kilos, has a rapidly failing transplant. And so we'd assume he has no kidney function, and he had been on Incenter, and he wants to try PD. And this man is he works, he likes to golf, he likes to go out. So this is where the prescription takes into consideration their lifestyle, because he doesn't want to be connected to the machine all day long, right? So then how would we determine the minimum amount of prescription? So the way I would do this, and this is so instructive of how a person size matters. So I like to always prescribe according to the volume needed per day, because then it's not a matter of number of exchanges, because that could vary determining the volume of inflow per exchange. So if we just assume the weekly peritoneal KT over V, at least in the US, has to hit 1.7, then we could just break it down here to the daily KT over V, right, of 1.7 divided by 7 days, which is 0.24 KT over V per day. Now we know that the KT over V per day or per week, doesn't matter, is equal to this is the equation, drain volume for that time period. So we're going to use per day, drain volume per day times how saturated is that drain volume with urea, which is determined by D over P urea, dialysate divided by plasma. But you can just think of this as percent saturation. All of this divided by volume of distribution. So this is where their body size comes in. So going back to this equation, so our KT over V urea is equal to the drain volume times how much it's saturated. The drain volume would be your inflow plus your UF. Whatever you put in 24 hours plus your UF, times how saturated it is divided by your volume of distribution urea. If you adjust this equation, you could just bring this V urea over to this side of the equation. So your KT over urea times your body size in volume, body water, V, equals your 24-hour drain volume, or your how much went in plus UF, times its percent saturation. So that's just really easy to do now, right? So if we did for this patient, we know his daily KT over V has to be 0.24. His volume distribution of urea, let's assume it's a man, 60% of his weight is total body water, typical for a man. For a woman to be 50%. So 100 kilos times 0.6 or 60% is, that would be 60 liters, right? So his daily KT over V has to be 0.24. 0.24 times 60 liters will give you his 24-hour drain volume times the percent saturation. So let's look at that. So his daily KT over V, 0.24, has to be 24-hour drain volume times percent saturation, all divided by his total body water. I'm going to bring this up on this side. So now KT over V times body water is going to be 12.96 liters. And that is equivalent to his 24-hour drain volume times how saturated it is. Now, for a longer exchange, like a 4-hour exchange, most patients will have 90% saturation. For a cycler exchange, this number might be closer to 80% or 0.8. So 24-hour drain volume times 0.8 will be a little bit higher than this amount, not by much, but if I did the calculation and I assumed that this total 24-hour drain volume were only 80% saturation with urea, then if I use 0.8 here, then this number turns from 12.96 liters per day required to about 14.4 liters per day required. Now, if you did not do this calculation, you would not necessarily know that this larger person needs 14.4 liters a day, and a typical 2x4 exchanges, 2-liter 4 exchanges, would not be sufficient. And I think that's instructive of like what Rod is asking, like how does the body volume take this into consideration? Now, of course, this doesn't have to be all dialysis in, because let's say he had 1 liter UF. Well, then that is full of urea. So this number could be 13.4. But still, how would you do that? So then that's the next question. So if his total drain volume were 14.4 liters, how could we prescribe that? Well, there's a lot of different ways. I mean, one way is to do 2.5 liters inflow for 5 exchanges, which would give you 12.5 liters with a 2-liter last fill. That alone would give you and a 1.2 liters of UF. So all of that together would be more than enough. But if you didn't do this calculation, you wouldn't realize that he might need more than 2-liter inflow overnight. How else could you do that? Well, this is a little more than he needs, right? So you could make this 2.5 liters something like 2.3 liters. How else could you do it? Well, if he only wanted, instead of 5 exchanges overnight, if he could only stay connected 8 hours, you could do 3 liters, and that's a lot, but he's a big person. But 3x4 gives you 12 overnight with a 2-liter last fill and a 1.2 UF. So then you get this much. Or you could do 2.8 liters times 4 plus 2.5 last fill. So these are just some examples of how a patient needs to have larger volumes if they're a larger person. And you wouldn't know this if you hadn't done all of this calculation. And people are getting larger around the world. Now, that said, if you did this the opposite way and you calculated for a small person, you might find that she only needs 6 liters a day. And so then instead of giving her 4 exchanges, 2 liters, maybe you just do 1.5 times 3. So these are some examples. Is that sort of what you were trying to get at, Rod?
Yeah, but I'd like to take it another step further and talk about how that KT/V of 1.7 was set and how dietary protein intake and BUN come into the calculation, because that 1.7 sort of makes some implicit assumptions about how much DPI the patient is taking and at what level of BUN the clinicians want to maintain that person at.
Oh, with that, yeah, I mean, I can talk like for hours on this topic. And does before I go into that topic, is there anybody on the call who wants to give their thoughts on that? Yeah. Well, I mean, so it's fun to have people who are not, to have nephrologists and nurses and people who aren't from the United States on the call, because oh, go ahead.
Sorry, I'm Dr. Noman Tari. I'm a CMO here in Byonyks in Pakistan, and I'm a nephrologist trained in Chicago. And just wanted to ask you, I mean, we are seeing most of the time people who are of a weight somewhere around 60, 75 kg or something like that. So as you rightly pointed out, we need to adjust the weight according to the KTOV. It's a good calculation. It gives you some, thinking process unless and until we get the new AI tools for that, and that will make us more lazy maybe. Uh, I had just a question that since you said, we have to start with incremental dialysis, it becomes very difficult when we ask our patients to make fistulas. They refuse right away. They resist dialysis. I mean, almost like 60-70% of these patients. And then ultimately we are able to get them on board for dialysis. So the recommendations of 10 ml GFR or less, maybe it's a little lower compared to a patient who may agree to a peritoneal dialysis with the incremental once or twice a week dialysis. So what's your thought about this? Should we just, like promote a little bit early dialysis if they want to start a PD?
And so I just need to take a step back. It might be different in Pakistan. Is there a requirement that you start dialysis less than 10 mLs per minute?
No, most of
Oh,
the literature does suggest that, okay, you can go a little slower and when the patient is there, and most of the patients think and they go through the Google and everywhere, and the suggestion is, like you go for dialysis at 10 and something like that.
okay. Right. So, I guess the way that in our clinic, the way we practice, and I will say a lot of this is dependent on how much time you have and how often the patients can come to your clinic. But I've always found the best, most effective way to start dialysis on a patient is to get them involved in the decision and do it jointly. And in that way, we in our clinics, we never have to determine an actual number of GFR. Unless it's something ridiculous like 4 mils a minute, then we say, yes, you have to start. But I think if you look at, like, for example, at the IDEAL trial, there was no set number that patients really needed to start dialysis on. Now, that said, the way I think optimally it's handled is to have something like a stage 5 CKD clinic where the patients come once a month and their symptoms are reviewed and they're part of that kind of discussion of when do we need to start. It gets a little tricky with peritoneal because you need to be able to get that catheter in pretty soon. But in this way, if you're seeing them every month, you have, probably a 3-week window to start the catheter, to get the catheter in. So I think optimally that's the best way, is just every month get their chemistries, hemoglobin, give them their erythropoietin if they need it, and check their symptoms. And any new onset of symptoms usually you'll catch within a month, like nausea, vomiting. Rarely does this start overnight. It might take several weeks. So I like to use that approach. And in that way, we never need to start anybody too earlier. Now, to your point, though, Dr. Tarif, I think, yes, in peritoneal patients, we would start them they typically would have a higher GFR in our clinics when they start. However, it's not because of their GFR, it's just because we caught a little bit of symptoms earlier. For example, it's just using kind of lower threshold of symptoms. So either loss of appetite, or now they're on max dose diuretics and their blood pressure is 160 and I can't get it any better and they're edematous. Or their epigen dose is now, erythropoietin dose is now 40,000 a week, and that's too much. Little things like that, or their phosphorus is out of control. Potassium's not regulated by potassium binders. So kind of a more nuanced use, and typically, yeah, their GFR will be a little higher, but a lot of times I think you'll find their GFR will be less than 10. In fact. So yeah, I think that's an interesting point, but I guess that just requires you to have the ability to see the patients often. And I think that's where, like, nurse practitioners or nurses even can help, check blood pressure, check edema, check weight,
Good.
things like that.
let's take some quick questions from the chat window. In respect, and thank you for everybody to join in. It's an amazing audience. So there's Abdul Hamdi, if I'm getting this name right. Sorry for that. What about keeping patients on ACEI, SGLT2I, and Lasix? I hope I'm reading for the maintenance of residual kidney function and membrane integrity.
Oh, absolutely, Dr. Hamdi. I think you're probably more aware of this than most people. So the majority of the larger countries' peritoneal prescribing guidelines all recommend ACE inhibitors or angiotensin receptor blockers, ARBs, in order to preserve residual kidney function, because we have data showing that it does. And these recommendations from Canada, UK, a number of countries recommend maximizing diuretics up to the point where you'll give somebody torsemide 100 milligrams a day or a furosemide 160 twice a day plus a thiazide. So there's no evidence that the high dose diuretics cause a decline in GFR. They don't, and they don't cause ototoxicity in oral doses, and they help reduce the hypertonic solution that you need. So I think all of those are wonderful. Now, SGLT2, there is no data, however, and it's not licensed, you're right. However, there isn't been any prohibition of continuing these SGLT2 inhibitors either. There is a trial, I believe, that's like in process looking at that, the SGLT2 in GFR stage 5 or below. So we still just have to be using them off label, in other words. But it doesn't seem to be any detriment.
Wonderful. So we are getting a lot of exciting questions, and they're coming in fast. I didn't let Doug ask any question, or we have to still answer Rod's question. But there's two questions. One, when to use icodextrin, and there's a Dr. Shazia's and Dr. Khalid question is, I will combine them. What is the role of low dialysate concentration in incremental PD?
Okay. So icodextrin has two, it's a harder question because it depends on the availability. So like, for example, in the US, we have shortage right now, but let's say we didn't have a shortage. When we didn't have a shortage, in our clinic where we don't have any major constraints, we use icodextrin overnight as our incremental prescription. 1 icodextrin overnight in patients who only need 2 liters a day. In patients who need 4 liters or fewer per day, we start most often incremental prescription is 1 icodextrin overnight and 1 3 to 4 hour like dwell in the morning or evening, and that's it. Dry day rest of the time. Now, our clinic does not have any financial restrictions. We don't have any administrative restrictions. Some clinics will restrict icodextrin to people who need a long dwell. So then if you're trying to be more cost conscious, I'd say anybody who needs anything longer than like a 6-hour dwell you can use icodextrin, but don't use it for fewer than 8 hours because you won't get the most ultrafiltration. So 8 hours exchange or longer, use your icodextrin. And it doesn't seem to have as many, so the patients who are higher transporters, so those you notice that they absorb fluid even with the 2.5 for 2 hours, the icodextrin, I would use it right away for any kind of longer exchanges. So any kind of long exchange, day dwell if they're on cycler, night dwell if they're on CAPD, that's when we use the icodextrin. And then the low dialysate concentration. So I think for any patient, no matter if it's incremental or not, we want to use the lowest glucose that we can, because Obviously, it's better for the membrane, fewer calories, less glucose exposure. Now that said, so let's say you are able to do shorter exchanges, then you could use a lower dialysate concentration of glucose. But your prescription also has to take into consideration how long the dwell needs to be able to get the solute clearance. So it's a balance. So use the lowest that you need. Just a really quick comment about the 4.25. I think the best thing to do is to reserve 4.25 for when you can't get UF with the maximum 2.5. And if you're going to use 4.25, my preference is to only use it intermittently and as like a rescue. For example, you have a patient who's a little fluid overloaded. Let's say their membrane is a very fast transporter. They will not do hemo, or they have an access and it's not ready for hemodialysis. Their membrane has failed. Maybe you use it once a week or twice a week, something like that. Or a patient's getting a transplant in 6 months. They're a really fast transporter. Again, use it, but using it every day, you're going to end up causing more damage to the membrane. So just be prepared that the peritoneum may not last that long.
Good. So we have 7 more minutes. Let's take some really quick question. Malik Rahman raised his hand. Do you want to go ahead and ask your question?
Can you hear me? So I'm Dr. Abdur Rahman from PIMS Islamabad, and my question is that it is clear from the literature that low transporters, they do good on CAPD, and the high transporters, they do relatively good on the APD. And preferably, I'm pretty sure that you are using it this way, that if somebody is having fluid overload issues, and then you put him on APD. But have you ever had an instance where you had a patient on APD and he was not doing well, and you had relatively lower KT or V values, and you had to switch that APD patient to CAPD? And my second question is that are we depriving the APD patients from the middle molecule clearance because the dwell time is low?
Yeah, those are great questions. I love those questions. So I personally, the way I believe is that the prescription, the type of dialysis, peritoneal, should take the patient preference into consideration. And so, just to even take a step back, in our clinic, we do not have a policy of prescribing according to their solute transport. What we do is we talk through with the patient what is their preference in terms of their schedule. So what is your daytime schedule? And when they come in, before they even get training, we'd find out how many hours do they sleep at night? Do they have nighttime commitments? We have several patients who are mothers to young children. They need to get up at night. I have one patient who's a caregiver for a 90-year-old. She has to get up at night. For them, they decided this APD is not going to work for them. Number two, we decide, is it going to be a caregiver? If it's a caregiver, clearly then the APD would be better. Number three, all of our patients are trained on CAPD for 1 month. And the reason is, and I don't think it's different in Pakistan, there are natural disasters. You might have earthquakes. We have earthquakes here, and we have in other parts of our country, there are hurricanes, just like there was this fall. So all patients, I believe, need to know how to do a manual, because what's going to happen when their power goes out? What's going to happen when the water, whatever it is? So 1 month on CAPD. After we do that, and this includes their 1 or 2 week training time. After we do that, what we found is we ask the patients, do you want to move on and do cycler? Do you like cycler? And most of these patients, by the way, have residual kidney function, so they don't need that much dialysis. If they do CAPD, it's not going to be all day. If they do APD, it's not going to be all night, all day. Then we ask them, are you interested to move to cycler? We'll show you what it is. 15% say no, 15 to 20. They say, no, I'm happy with what I'm doing now. I'll think about it. And in that way, they are bought on to their therapy. They are part of their therapy. And this helps them stay on the therapy longer. they feel like they're part of the program. And this is why I think this is one of the things that's missing in the long-term PD. If you want patients to stay on the therapy, then they have to feel like they're part of it. You're not giving it to them. They're doing it because they want to. So in terms of changing a patient from AP to CAPD, we have done, so we've never, rarely have point blank done that, only one time. Typically, it's a conversation. So we would tell the patient, look, you're not doing well with these short exchanges. We need to have longer exchanges. And it's happened only a few times, but what we've ended up coming up with is a longer cycler time, 10 to 11 hours, with only 3 cycles during that time, and then 2 daytime exchanges, 1 or 2. And so it's like a pseudo CAP, it's like a hybrid CAPD, APD. It's using the cycler like a manual. And this way, it preserves the patient's preference for keeping part of the day the machine and not having to do all these CAPD exchanges. So that's the part one. Sorry, I've forgotten part 2 of the question, the comment.
We can
the part 2 of the question was that are we depriving the APD patients from the middle molecule removal because the dwell time is low?
Yeah, yes, I think we are. And in some ways, it depends. If they have residual kidney function, you have the middle molecule clearance from that residual kidney function. But as soon as you see their phosphorus rise without a change in diet, without a change in binders, or their creatinine suddenly rises from 13 baseline to 18, these are the signs that their middle molecules are not being cleared as much. This means they do need either a day dwell if they don't have one, or some way to increase their longer dwells or middle molecule, maybe more convection, which is somebody else's question a little bit later on. So I think when they have residual kidney function, my opinion, I mean, what I've seen is no, they're not. But once they lose residual kidney function, I don't think a patient should ever have a dry day, never, ever, if they have no residual kidney function, because there's no other way you're going to get the middle molecules unless you have a long dwell during the day. And that's a great question for everyone to learn from. So thank you for asking that.
So we need to be respectful of her time. She has to have some family commitments. It's exciting. So many people are coming in. It's one of the most exciting sessions. You're a real crowd puller here. So just quick, 1 or 2 things. We can. There's a question about potassium. Rod has a question. I would let you answer whatever you can, and then I will wrap this up. And we will request more time from Dr. Saxena some other time, and maybe around January timeframe after the holiday season. Thank you, Dr. Saxena. I will let you pick up the question 1 or 2, and then I will let you wrap this up.
Yeah, absolutely. I think there are just like 2 quick questions. So there's one on beta 2. So I think that would be, we already covered that one. There was a question about potassium. So no, it's definitely not recommended to add potassium to PD fluid. It's probably best not to add anything to the PD fluid. But I will say a couple of things about potassium. One is that if you go ahead with your ACEs and ARBs, as our esteemed physician earlier mentioned, Dr. Farkar and Dr. Hamdi, then if you keep them on ACE and ARBs, you're going to have some potassium retention. So that helps your hypokalemia. You can add spironolactone. And then remember that the high potassium foods are good for fiber, and they help keep your bowels moving, which helps your catheter move. The catheter work better. So get them to eat the broccoli and the spinach and everything that is high in potassium and high in fiber. Mango, papaya. These things help the potassium and they help the bowels too. So that's the potassium question. And somebody said they could help with the AI question. So we'll like to hear about that. Then somebody, KT over V is no longer a criteria. Yeah, it's not a criteria in your country. I wish we had that problem here, but we don't. And that's a whole nother, I have a whole lecture on KT over V urea. So we'll get to that. But but Broad had a good point I think he was trying to make, which is that sometimes when we try to optimize urea clearance, one of the ways to do that is unfortunately ends up restricting protein intake. Right. So that was one of the problems with early in the 90s, or no, the 80s, right? The 70s and 80s, patients were being restricted. And Rod, you're muted.
Yeah, that was the experience with intermittent peritoneal dialysis, where they found that by inadequately dialyzing the people, they would respond by restricting their dietary protein intake. Their BUN would look good, but they went into a downward death spiral.
Exactly. So yeah, that definitely not. So looking at all the parameters, their volume status, their phosphorus, their potassium. Yeah, like for example, a high potassium in a PD patient might signify poor clearance. They probably need a little bit more. Or a very high phosphorus could be good diet, but they should be getting a long exchange. So I think just one last question. There was somebody who asked, when do you decide to switch to hemo? So I think it's such a hard thing, and it again should involve the patient, and probably should not be done, if possible, in an abrupt manner. So if your patient's starting to get fluid overloaded, for example, you need to start using 4.25 2 or 3 times a week. And you're optimized on diuretics, you're optimized on fluid restriction. That's one example of when we need to start thinking about a fistula. Or they're not meeting, they're starting to have nausea, they're not meeting clearance targets, whatever you decide to measure. We should be seeing these things addressing them early and saying, look, it looks like we might be headed towards the membrane not working. Or you can do a 4.25 PET and they don't meet the targets. They don't get 400 cc's of UF with a 4.25, and they don't have sodium sieving anymore. So these are all different ideas, but hopefully assessing the patient regularly, you can see these coming and keeping them in the conversation, so that they understand it's not that you're removing something from them. You're trying to help them feel well, so that they're on board with this.
I think we took a lot of your time. We need to end the session. She has commitments. We are very thankful to you, and it's a great crowd. Thank you everyone for the participation. We will let you go, and we will be looking for our 1 hour here and there from you if you have time. Very excited. There's so much more to learn from you.
Oh, thank you, everyone. These are such great questions, such a wonderful. I'd love to do this again, and thank you all. Thanks for inviting me.
Thank you.
Thank you.
Okay. Bye-bye.
Thank you very much.